One thing that we really saw is how some of the smaller visits, the pregnancy tests, the emergency contraception visits, those were instances when clients would disclose the most.
One visit that comes to mind is a woman who came in just to get more birth control pills and also to get emergency contraception. And in the past, we may not have even asked anything at that kind of visit, but we asked her if she felt like her partner was trying to get her pregnant, or if she was concerned that her partner wanted her to get pregnant when she didn't want to be. And she started to think about the fact that she needed emergency contraception because she's been missing pills a lot. And she started to think about where those pills were. She realized in that moment that her partner was trying to get her pregnant, and maybe she should choose a method that he wasn't going to be able to mess with.
If the provider community can embrace the methods of asking the clients that they're working with questions in a different format, probing in a different way, I believe we can be even more successful in preventing unintended pregnancies and providing a service to our clients that not only protects their reproductive health, but empowers them to be advocates for themselves.
You've heard about reproductive choice. We're going to talk now about reproductive control. That video and a new report comes from, among others, Planned Parenthood and the UC Davis University of California Medical School. With us to talk about that report, which is mentioned in a new article in The Nation magazine, available at thenation.com, When Teen Pregnancy is No Accident, the author, who's also the author of Death by Chicklet, Lynn Harris. Thanks for coming in. And with us, Dr. Elizabeth Miller, who is a professor and clinician at UC Davis. Let's start with this whole concept and an issue that has only recently come to the fore. Lynn, start with you. How did you hear of this issue, and how did you find the data that you've discovered?
I first read a couple of years ago, actually, about a very small study that Dr. Miller did, and she can tell you more about it, but in which she did a very small study of girls in Boston who were already at risk in some way or another of various problems. And the numbers she found among them of girls who had been coerced by their partners to get pregnant, coerced by their partners to have an abortion, whose partners had hidden their birth control, who were hiding their birth control from their partners so they wouldn't mess around with it, and who had experienced all of those types of reproductive coercion were stunning. And that was just a tiny little study that, and as Dr. Miller will tell you, she went on to do more. And what people are finding is that, and it's something that's been known to those who work directly with teens and young women for a long time, but now we finally have larger and larger amounts of data to show that there is this thing going on called reproductive coercion that turns on its head the notion that it's, or the myth or the fable, that it's always women who are trying to trick their boyfriends into getting them pregnant.
What was the case that awoke you to this problem, Dr. Miller?
So now about 10 years ago, when I was working in a confidential teen clinic in a youth agency in Boston, I had a 15-year-old girl come in for a pregnancy test, which is pretty routine adolescent medicine. Her pregnancy test was negative. I swung around and I said, so your test is negative. What are you using for birth control? And she said, nothing. And I said, oh, well, here are all of your options. And very quickly I assumed that she just needed to be educated on the different types of contraceptive options. Somewhere along the way, I asked her about whether she felt safe in her relationship and whether her partner would use a condom. And I got sort of a shrug and a whatever. I handed her a brown bag full of condoms and said to her, now you come back any Thursday night when I'm here so we can talk about what birth control is right for you. And 2 weeks later, she was in our emergency room with a severe head injury, having been pushed down the stairs by her boyfriend. And I have to say, every time I tell that story, I get the chills up and down my spine because it was by far the most destabilizing experience as a clinician. I had actually done work on training healthcare providers on domestic violence prior to that, and really thought I knew how to identify domestic violence in the clinical setting. And what I missed that evening were multiple red flags, including a young woman who was not using birth control, and how quickly, as a clinician, I assumed that it was a knowledge deficit as opposed to the possibility that her partner might have been interfering with her ability to contracept.
Lynn, to you, as you reported on this story, you did find many doctors, like Elizabeth, who are becoming aware of the warning signs. For people maybe watching or listening out there, what are some of those signs?
Well, what we really know overall is that now, in terms of relationship violence and intimate partner violence, the warning signs are not necessarily just a bruise, a broken limb, other visits to the emergency room. The warning sign could, in many cases, be a pregnancy. Or, alternatively, it could be abortion, repeat abortion. It could be repeat STD testings. It could be an STD. In that way, reproductive coercion is really the most secretive, stealthy, possibly even in certain ways, the most life-altering type of domestic violence.
Do we know anything, Dr. Miller, about why this is happening, meaning why men abuse like this and boys? Because some of the people you're talking about are very young in this study.
Absolutely. So I think our research on men and boys is still very much in its nascency, and we have only started some qualitative work in this area. What I can tell you is that there is a whole range of reasons that young men may try to get their female partners pregnant. It can include everything from wanting desperately to have a nuclear family of their own that they never themselves experienced, meaning that they've come from dysfunctional, maladjusted homes, and they just simply want to have a family. Or it may be more complicated in that a number of young men who are gang involved, for example, will their seniority within a gang is measured by the number of babies' mamas, so the number of women who they have impregnated, and the reasons go on. So there is a whole slew of reasons. I think probably the biggest one to underscore is control. It's the ability to try to maintain control in a relationship. And among the women that we have interviewed about this phenomenon, the number of women who say he wanted to get me pregnant because he wanted to leave a legacy is something that we hear a lot. So I think there are, yes.
Yeah, I mean, Lynn, to you, it makes me think, obviously it's not just people who have a relationship to gangs that are at this moment feeling fragile, unstable, at risk. How does the economic environment, any of this stuff affect what you're seeing and what people are seeing in the hospitals across the country?
Well, one thing I do know is that I have interviewed, there's another expert I interviewed named Dr. Jill Murray, who works directly with teens quite a bit in schools and in other settings. And she says that even though, as Dr. Miller explained, a lot of this is maybe associated with gangs, she also said that she goes into schools in every zip code, in schools in every economic stratum, and she sees it everywhere.
So what can be done, Dr. Miller? I mean, I understand that there are programs that are getting into place. At UC Davis, you're working on some of them. What can be done to help the women, help the boys?
Absolutely. So let's start with clinical interventions first. You started with the story of our work with Planned Parenthood, where we have been training clinicians, and this includes health educators as well as the nurse practitioners and physicians in reproductive health clinics, to really understand the extent to which partner violence affects the women that they care for, and now reproductive coercion. So what we have been doing is training clinicians to ask questions differently. When a woman comes in for a pregnancy test, in addition to asking her if this is a pregnancy that she desires, to also ask, is this a pregnancy that your partner wants? And how might your partner react if this test is positive? So that the questions that are asked are integrated into the reproductive health visit. In addition to working on clinical interventions, though, I'm very focused on prevention. And one of the things that we are finding is, no surprise, that reproductive coercion is very closely associated with unintended pregnancy. This means that teen pregnancy prevention programs, teen pregnancy prevention education in our schools across the country really need to incorporate a discussion of pregnancy coercion and sexual coercion very explicitly into the curriculum.
This is a call I'm hearing for, again, a clearer, more comprehensive concept of reproductive health?
Well, comprehensive is the key word. I think, for one thing, we can see yet another weakness of abstinence-only education here. I mean, how can you look a young girl in the eye and say, use your willpower to resist sexual urges, when she's going home to a guy who is using his willpower on her, or will on her? And at the same time, I think as Dr. Miller was saying, if you think about sex ed, it's really, in many cases, about reproduction, and it needs to be about relationships. And all of the issues that young kids face, or even not even young kids, young people face, have to be merged together. You can't really talk about substance abuse one week and then talk about dating violence as distinct from how you get pregnant, as distinct from all the other challenges.
The article, When Teen Pregnancy is No Accident, is at thenation.com. The author, Lynn Harris, thanks so much for being with us. And Dr. Elizabeth Miller, thanks for joining us from UC Davis.